In this video, we're going to be talking about updates in endocarditis, and I'm going to be sharing with you many of the pearls that I've learned about endocarditis over the past several years. So the first thing you need to know about endocarditis is how to classify it. First of all, you have infective endocarditis and non-infective endocarditis. The reason you can get non-infective endocarditis is because of the formation of fibrin thrombuses. So this could be due to a hypercoagulable state, rheumatologic disease like lupus, so Liebman-Sachs disease, or due to malignancy. And the ones that are most commonly associated with that is pancreatic adenocarcinoma and colon adenocarcinoma. Another name for it is non-bacterial thrombotic endocarditis or merantic endocarditis. Going back to the infectious endocarditis side, you've got culture positive, which is typically also the acute infectious endocarditis, and culture negative endocarditis, which often can be the subacute or chronic endocarditis. About 25 to 31% will be culture negative. And what organisms cause culture negative endocarditis? That's going to be the Hayseck organisms, of which the most common cause is Coxiella. One thing to note, however, is that modern blood cultures are better at detecting Hayseck organisms than they used to be in the past, and so the incidence of culture negative endocarditis is actually decreasing. It just sometimes takes a little bit longer for these bacteria to speciate, usually after 5 days of incubation. Taking a look at this picture here, you can see the common organisms that you'll see in acute endocarditis or culture positive endocarditis, and that's going to be things like Staph aureus, strep, and enterococcus. And then on the subacute or chronic side, these are going to be where you have those culture negative organisms like the Hayseck, Fastidious streptococci, Brucella species, and Q fever. This is a common board question, but if you ever see anyone with strep bovis or galloliticus endocarditis or bacteremia, what is an additional test that these patients will need? That's going to be a colonoscopy to rule out colon cancer. And again, if somebody has E. faecalis of unclear source, this one will also need a colonoscopy if they're in the age range for appropriate screening. This is because 50% of these patients had an underlying neoplasm per this article in 2017. You can see on this picture also, we're talking about native valve endocarditis up here, and then we've got prosthetic valve endocarditis over here. And the main thing that you need to know for prosthetic valve endocarditis is that you usually need to add gentamicin. So remember the basic framework of infective versus non-infective, and then acute versus subacute, or culture positive versus culture negative. Now let's talk about the most common presenting symptom of endocarditis. If you could pick any one symptom of endocarditis, what do you think is the most common? And actually, it's fever at 93%. 93% of patients are going to be febrile. And you can see this other article here also saw fever in 90% of patients. I bring this up because some of the things that we look for on physical exam, like Roth spots, Osler nodes, and splinter hemorrhages, they are actually quite uncommon. So if you go here, you can see that splinter hemorrhage is at 27%, Osler nodes at 12%, and Janeway lesions 5%, things like that. It's also interesting to note the percentage of cases that initially present with embolic complications such as septic emboli or stroke, and that's going to be 25%. So let's move on to diagnosis, and one of the first questions is, how many blood cultures should you send if you are suspicious for endocarditis? Typically, we send 2 sets of blood cultures on patients coming in with sepsis, but actually, when you're suspicious for endocarditis, it's actually recommended to send 3 sets of blood cultures per the 2023 ESC guidelines. And by 3 sets of blood cultures, we're talking about each set having 2 bottles, 1 aerobic bottle and 1 anaerobic bottle, so 6 bottles total. The reason for this is based on this 2007 study, which identified the percentage of bacteremia based on the number of blood cultures obtained. So the first set of blood cultures identified bacteremia 73.1% of the time. The second set identified it 89.7% of the time. And the third set identified it 98.2% of the time. Once you get to the fourth set, then you're starting to get a little bit of diminishing returns. But this is why for endocarditis, which is when we really need to have a sensitive test to see if they're bacteremic or not with a typical organism, that's why we need to get 3 sets in these patients. You're probably familiar with the Duke criteria, which is what we use to diagnose infectious endocarditis. And so you have major criteria and minor criteria. So per the old Duke criteria, the 2 major criteria was having positive blood cultures with a typical organism and then positive echo findings. The minor criteria included a predisposition to infectious endocarditis, such as IV drug use, predisposing heart disease, or a cardiac implantable device. a fever, vascular phenomena, immunologic phenomena, and microbiological evidence not fitting the major criteria. This was kind of including things that were tested serologically, or if you had a positive blood culture with an atypical organism. So you have definite infectious endocarditis if you have 2 major criteria, 1 major plus 3 minor, or 5 minor. And for possible infectious endocarditis, it's 1 major plus 1 minor, or 3 minor. But in 2023, we actually had a major update to the Duke criteria, and it added several things to both the major and minor criteria. So major criteria now includes positive lab tests for Coxiella, Bartonella, Trophorema, and antibodies. Cardiac imaging and PET-CT imaging has been added, and surgical evidence have all been added to major criteria. And then on the minor criteria side of things, PET-CT less than 3 months since cardiac surgery, and a new regurgitant murmur when an echo is unavailable has also been added to the minor criteria. Here's just some references in case you want to take a look at the updated 2023 Duke criteria. I want to address the immunologic phenomena and the vascular phenomena. So what specifically are we talking about with these criteria? So immunologic phenomena include things like Roth spots, which you're going to see on an eye exam, or Osler's nodes. And the vascular phenomena are going to be more of the splinter hemorrhages and the Janeway lesions. So how do you differentiate between Osler's nodes and Janeway lesions? First of all, the location can sometimes be helpful, as the Osler's nodes are more on the digits, whereas the Janeway lesions can be more on the palms. But a common way to remember it is that Osler's nodes are painful, so they're called Osler's nodes. So here's a summary of the immunologic phenomena: glomerulonephritis, Osler's nodes, Roth spots, and rheumatoid factor. And vascular phenomena are going to be arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhages, or Janeway lesions. And then in terms of which side of the heart can lead to these phenomena, immunologic phenomena are mediated by complement, and so it doesn't matter which side the heart the endocarditis is on. These immunologic phenomena can occur whether or not you're left-sided endocarditis or right-sided endocarditis. Whereas the vascular phenomena is only going to occur in left-sided endocarditis, because if you think about having a vegetation on the left side of the heart, that can shoot off and cause a stroke and get into the systemic circulation. Whereas on the right side, you are not going to have those systemic emboli. However, there is the exception of pulmonary infarcts or pulmonary septic emboli, which you could see on the right side. One of the things that could be helpful if you're struggling to diagnose infectious endocarditis is checking for signs of glomerulonephritis and rheumatoid factor, because that can actually get you some of the minor criteria for diagnosis. So consider checking complements, urine studies, and a rheumatoid factor if having difficulty making the official diagnosis of infectious endocarditis. Let's say you have a patient who is bacteremic and you are concerned they could have endocarditis, but the imaging has been negative so far. Are there any prediction tools that can help you assess the risk of infectious endocarditis? So there are actually several clinical prediction scores for endocarditis in patients with staph bacteremia. So you can see the positive score, the predict score, and the Versta score. And the one I want to address is the Versta score, which I've seen used in our hospital, but basically get several different points based on specific findings that you may see. So in the Versta score, a score of 2 or less had a 1.1% risk of infectious endocarditis, with a negative predictive value of 98.8%, and a score of 3 or more had a 17.4% risk of infectious endocarditis. This was again validated in 2021, and basically this can be used to help prioritize which patients should undergo urgent echo versus possible TEE. Is it ever worth it to get repeat echoes looking for endocarditis, even if the initial echo was negative? The answer is actually yes. It's actually recommended to consider repeat TEE or TTE after a negative result if clinical suspicion of infectious endocarditis persists. The AHA recommends to get a repeat echo 3 to 5 days later, and the ESC recommends to get a repeat echo 5 to 7 days later. And the reason this is beneficial is because the highest sensitivity for echocardiography when we're looking for endocarditis is 5 to 7 days into bacteremia. What about the sensitivity of TTE versus TEE for evaluation of endocarditis? How well do they compare with each other? So the sensitivity of TTE is actually only about 40 to 75%. So that's why getting that repeat echo or moving on to a TEE is oftentimes the next best move if your suspicion is still high. The TEE, on the other hand, has 90 to 100% sensitivity. Now let's move on to talking about treatment. So what is the typical antibiotic duration for uncomplicated Staph aureus bacteremia? That would be 2 weeks. You can see based on this study in 2013 and the 2011 IDSA guidelines, uncomplicated bacteremia should be treated for 2 weeks. How about the typical antibiotic duration for right-sided endocarditis? That would also be 2 weeks, and this is due to the lower bacterial density that's present compared to left-sided endocarditis. So you can see from the study in 1988, a 2-week course of antibiotics cured 94% of patients, and the 2015 AHA guidelines also recommend 2 weeks of therapy for uncomplicated right-sided endocarditis. In contrast, the typical antibiotic duration for left-sided endocarditis is 4 to 6 weeks, and what I've usually seen is 6, and especially if it's complicated, they may even prolong the duration even further. One of the most common things that comes up is what time point is considered the first day of antibiotic therapy. So it's actually not the first day that the patient received antibiotics, but they actually start counting from the first day of negative cultures. So let's say a patient had repeated positive blood cultures and they were only finding negative at day 7, then even though you've already given 7 days of antibiotics, day 1 would be the first day of negative blood cultures. Is there any evidence for using shorter durations of IV antibiotics and maybe switching patients over to oral therapy so they can take it at home? So there's actually this pretty important trial that came out in the New England Journal of Medicine in 2018 called the POET trial. And the reason this study is important is because many patients require extended hospital stays due to the need for IV antibiotic therapy, which is often associated with worse outcomes. Outpatient IV therapy, I'm sure you've all tried setting this up, has a lot of logistical issues. It can be very hard to set it up and requires complex care coordination and can be expensive. Outpatient PICs are often not offered to patients with history of IV drug use. So potentially, if we could switch these patients off of IV antibiotics early and switch them to oral antibiotics, they may be able to go home earlier, reducing their duration of hospital stay and improving their outcomes. So the POET trial was a randomized, unblinded, non-inferiority trial done from 2011 to 2017 and assessed 400 stable adults with left-sided endocarditis. So the treatment they compared was just doing the standard full IV antibiotic therapy versus starting with IV antibiotics and switching to PO antibiotics. And they looked at a primary outcome of all-cause mortality, unplanned cardiac surgery, embolic events, or relapse of bacteremia. And they found that the primary outcome was seen 12.1% in the IV group versus only 9% in the oral group. So it was actually better in the oral group. Some notes on the study was that the median days on the IV therapy was 17 days. So most of these patients still did about 2.5 weeks of IV therapy. But then after the 2.5 weeks, continued to do an additional 19 days, versus the PO group was able to switch over to PO and they completed a median of 17 days. And the most common regimens were a beta-lactam plus rifampicin or moxifloxacin or linezolid. The median length of stay, this was a pretty important one, after randomization was 19 days in patients receiving only IV antibiotics versus just 3 days in patients that were switched to PO regimens. And the subsequent follow-up at 5 years showed that the primary outcome occurred less frequently in the PO group at 32% versus 45%. So all of this data was very promising to advocating for a switch to PO. However, there were some criticisms of the study. So first of all, they only evaluated left-sided endocarditis, and 25 to 30% of patients were excluded due to having less typical organisms. Only 1% of patients had IV drug use. The patients in the oral group had extremely close follow-up, which may not be as feasible in the real world. And a high proportion of strep patients, 49%, versus less Staph aureus of only 22%, which kind of is not accurate to the typical numbers that we see, which is predominantly Staph aureus. And they also had no MRSA patients. However, I think this is very promising, and it would be really great if we had some more studies validating the early switch to PO antibiotics, because that would help these patients be able to get home so much sooner and avoid them having to get PICC line, home health nursing, home infusion companies, all of that stuff. Is IV drug use a a contraindication for placing a PIC so that somebody could get outpatient IV antibiotics. This one was pretty surprising to me because I'm sure we've all trained that we should avoid placing PICs or central lines in patients with IV drug use. You can see in this 2004 IDSA outpatient parenteral antibiotic therapy guideline that injection drug use or alcohol abuse problems should be specifically evaluated before therapy is initiated. Patients who are likely to abuse a vascular access system are poor candidates for OPAT. A skilled nursing facility may be the most appropriate. You can also see a survey of infectious disease physicians that shows that most of them are unwilling to do OPAT for patients with IV drug use. You can see that 35% of the time they transferred the patients to a SNF to complete IV antibiotics. 41% of the time, they just kept them inpatient the whole time to finish their whole antibiotic course. And even if the patients had clear evidence of sobriety, 37% of ID physicians rarely gave them OPAT as an option. And if they had stable opioid use disorder on opioid replacement therapy, 40% of ID physicians said they never provide OPAT to these patients. And again, 32% also said they rarely provide it to these patients. And these are the patients that basically have pretty good evidence of sobriety. They're stable on buprenorphine or methadone for years, or it's been like 5 years since they've had any use. Even in these situations, people are hesitant to give them a PIC. So there's been a review of the literature recently in 2018, looked at multiple different studies, and they actually recommended that a history of even recent injection drug use should not automatically exclude candidacy for outpatient parenteral antimicrobial therapy. Emerging literature has demonstrated that selected patients with IV drug use have good outcomes participating in OPAT for infectious endocarditis and comparable invasive infections. So let's look at the study. There were 10 studies identified with 800 individuals, mostly with recent IV drug use within the last 4 weeks, 3 months, or 12 months. The OPAT completion rate among these 10 studies was fairly good, ranging from 72 to 100%, and the mortality was 0% in 7 studies. 3 of the studies did have a mortality rate of 1 to 10%. However, the deaths did not appear to be IV drug use related. So this is probably the major reason that we are avoiding placing central lines in these patients because we're afraid that they're going to misuse the line, inject IV drugs through the line. But based on these 10 studies, we really did not see any increase in these events. The outcomes were comparable, but patients with IV drug use actually had lower complication rates, 1.3% versus 2.2%. They did have higher non-compliance rates of 6.4% versus 0.61%, and they only found a 0 to 2% incidence of misuse of the PIC. So based on this review of published studies, OPAT for people with IV drug use may be as safe and effective as OPAT for patients without a history of IV drug use. Rates of OPAT completion, mortality, and catheter-related adverse events were comparable. The rate of misuse of the venous catheter was low, and cost savings could be substantial, especially as the opioid epidemic continues to grow. All right, now let's talk about how to choose between different antibiotics for treatment of endocarditis. So how would you choose between nafcillin and cefazolin, for example? And why is vancomycin actually not preferred for treatment of methicillin-susceptible Staph aureus? So why is vancomycin not preferred for methicillin-susceptible Staph aureus? The reason is because vancomycin only has what's called slow bactericidal activity versus MSSA, whereas nafcillin and cefazolin have true bactericidal activity. And if you're actually treating enterococcus, vancomycin is actually only bacteriostatic against that, and you would actually need a second agent in order to treat that. Should you use nafcillin or cefazolin for initial treatment of infective endocarditis? The answer is nafcillin. This is preferred up front. So some of the differences between nafcillin and cefazolin is that nafcillin is Q4 hours and it has more side effects, whereas cefazolin is Q8 hours. It's more tolerable, easier to administer, and generally they recommend switching to this after 4 to 10 days of treatment. So why is nafcillin considered superior to cefazolin up front? The reason for this is because there's something called the inoculum effect. And basically what this describes is when you have a very high burden of disease, there is actually a lot of beta-lactamase activity that can reduce the efficacy of cefazolin, whereas the inoculum effect does not really affect nafcillin as much. And so that's why you start off with nafcillin, get rid of a lot of that burden of disease, and then after that you can switch over to cefazolin once the inoculum effect is going to be less of a concern. In addition, nafcillin has CNS penetration, so if anybody has meningitis or brain abscess, the nafcillin is also superior to cefazolin due to increased blood-brain barrier penetration. What is the preferred IV antibiotic for MRSA endocarditis? That would be vancomycin. And what is a long-acting version of vancomycin that you could potentially give somebody so they don't have to get a PIC and prolonged IV antibiotics? That would be something called dalbavancin. So it's a very good option, especially in those patients who are not candidates for PICs. And then what is the IV antibiotic of choice if a patient is responding poorly to vancomycin, they're unable to tolerate it, or there's concern that the bacteria is resistant to it? That would be daptomycin. However, monotherapy with daptomycin is not recommended up front. Usually we start with ceftaroline plus daptomycin for the first 72 hours. Is there any role for aspirin or anticoagulants to reduce the risk of stroke in patients with endocarditis? The answer is no. This has not been shown to have benefit. So some of the risk factors for embolization include a large vegetation greater than 10 millimeters, location on the mitral valve, or Staph aureus endocarditis. And if somebody does have a stroke, should you then start antiplatelet therapy in the setting of infectious endocarditis? The answer is no. You should also actually stop anticoagulant therapy for 2 weeks to reduce the risk of hemorrhagic conversion. These strokes due to septic emboli are actually very prone to bleed, and so that's why we stop the anticoagulation. If a patient has endocarditis, should you remove their implantable cardiac defibrillator or pacemaker, even if it does not appear to be infected? The answer is actually yes. So in this article on UpToDate, under removal of cardiac devices, removal of cardiac implantable electronic devices may be indicated even if the device appears to be uninfected. Observational studies have identified higher survival rates in patients with cardiac implantable electronic devices with left-sided endocarditis who have undergone extraction of the entire device. Here you can see this article from 2023 looking at cardiac device-related infective endocarditis, and they were looking at apparently non-infected cardiac devices, and they found that device removal was associated with better prognosis, even in the patients with left-sided endocarditis and apparently non-infective cardiac device. What if a patient with endocarditis develops first-degree AV block? What could this be due from, and what would your next step be? Well, first-degree AV block, are we thinking that, that's fairly benign, we don't really care about it? But then it's like, oh, why are they all of a sudden developing this? So in this case, if there's somebody with endocarditis, what you have to be concerned for if they develop any changes in their EKG or in their telemetry is for a perivalvular abscess. So the reason is because all of the cardiac conduction pathways run down this septum right here in the center. And also, you've got your SA node, your AV node. And once you have an infective vegetation here, it can actually start growing and affecting the conduction system. So immediately, if you start to see any new conduction defects, you have to be very concerned because it can progress quite quickly and lead to complete heart block. In this case, you should undergo a TEE to assess for that abscess and obtain possible surgical consultation. What are the indications for considering surgical management of infectious endocarditis? So for left-sided endocarditis, if you see any valve dysfunction leading to congestive heart failure, that's an indication to consider surgery. If there's a perivalvular abscess, a penetrating lesion such as a fistula, a large vegetation greater than 10 millimeters, or a difficult to treat pathogen or persistent infection. For right-sided infectious endocarditis, it's fairly similar, but the cutoff for a large vegetation is larger at greater than 20 millimeters. If you're having recurrent septic pulmonary emboli, if you have a highly resistant organism, a persistent infection, or less commonly, right heart failure, heart block, or a perivalvular abscess. So if you see any of these complications arise in your patients with endocarditis, you should get cardiothoracic surgery on board immediately to evaluate if these patients would benefit from surgery. Should you be concerned if a patient with endocarditis is still febrile 5 days after starting treatment? The answer is no. Defervescence often takes 5 to 7 days after the initiation of therapy. So don't be surprised if it takes them a while to defervesce. Right-sided and septic pulmonary emboli may take even longer. Should you obtain a new baseline echo at the end of treatment? The answer is actually yes. And actually, it's quite common, even after the completion of treatment, that you'll see persistent vegetations. So complete resolution of vegetations by the end of antimicrobial therapy is uncommon, even with successful treatment. So if you finish 6 weeks of antibiotics, you get that repeat echo, and there's still some vegetation there, this shouldn't necessarily be cause for alarm and may be expected. All right, here's again the summary of everything we covered covered today. So the main categories of endocarditis: infectious versus non-infectious, acute versus subacute, and culture negative versus culture positive. Get those 3 sets of blood cultures on admission. Know the updated 2023 Duke criteria, the difference between immunologic versus vascular phenomena, the Versta score for predicting endocarditis, knowing that there is utility of getting a repeat echo if the initial study is negative, knowing the duration of right-sided endocarditis, if it's uncomplicated, can just be 2 weeks versus left-sided, which is at least 4 to 6 weeks. You should know that the POET trial may lead to shorter durations of IV antibiotics in the future, since we may be able to switch to PO. IV drug use may not be an absolute contraindication to OPAT. Knowing the differences between vancomycin, nafcillin, and cefazolin, there's no role for antithrombotic therapy to prevent embolism. Consider removal of cardiac devices even if not infected. Know the indications for surgery. Know that defervescence may take 5 to 7 days, and that a baseline echo should be obtained and may still show vegetations even after the end of treatment. I hope there were some useful pearls on endocarditis in here for you guys and some useful updates for 2025. Write a comment down below if you have any questions. Thanks again for watching, and I'll see you in the next video. Peace.